Welcome to AETCM Emergency Medicine Channel. Shall I start, sir? One 70-year-old male patient presented to ER with complaints of generalized tiredness followed by weakness of the right lower limb associated with numbness of the same area lasting less than 30 minutes 1 hour back, and while presenting to ER, patient is asymptomatic. On arrival, initial 10-second assessment, patient is conscious oriented and obeying commands. Airway is patent, no pooling of secretions, no gargling. Breathing, saturation is 100% in room air. Respiratory rate is 18 per minute. Chest air entry bilaterally equal. Circulation, BP is 160/80. Pulse rate is 72 per minute and peripheral pulses equally felt. Disability, GCS is E4, V5, M6. Pupil equal and reactive to light, moving all 4 limbs. Exposure, febrile. GRBS is 186 mg per dl. As primary adjunct, we took one ECG which shows normal sinus rhythm with left ventricular hypertrophy LVH features, and VBG, no acid base abnormalities, no electrolyte abnormalities. CBC CRP, HB is 10.2, platelet is 212,000, WBC 7,000 and CRP is 7.2. Ample history, not allergic to any medications. Patient is non-case of diabetes on OHA, glimepiride metformin combination, hypertensive on clinidipine 10 mg, and history of smoking and daily alcohol consumption. And the events leading to this: 70-year-old male patient, non-case of diabetes, hypertension, presented to the ER with complaints of generalized tiredness followed by weakness of the right lower limb associated with numbness over the same area lasting less than 30 minutes 1 hour back, and he is asymptomatic while presenting to ER. No history of headache, no history of seizures, facial deviation or slurring of speech, no history of loss of consciousness, nausea, vomiting, no history of trauma, no history of giddiness. And on general examination, no pallor, icterus, clubbing, lymphadenopathy, edema. Speech is normal, no facial palsy features, pupil bilaterally equal and reactive, power is 5/5 in all 4 limbs, sensation normal, tone is normal, deep tendon reflexes is 2+ with normal plantar response, and cerebellar signs are negative. So since the patient has no typical feature, any limb weakness and all, we suspected it as transient ischemic attack. So initially we done the ECG to rule out any atrial fibrillation, and we check for the CBC CRP for any drop in HB, anemia is there, and also VBG to look for any electrolyte imbalance like hyponatremia, and also check for GRBS for any hypoglycemia features. And after that we do one MRI, brain with MRI.
For that, check. When you're dealing with a TIA case, you tell me, when you examine a patient, what is the importance of pulse, BP, saturation, all vitals in a stroke case?
Sir, in a stroke case, if it is a stroke case, we have to look for why the stroke happened. Is there any hypertensive features?
You take pulse. What is the importance of pulse?
Pulse, we have to check it is irregular
for rhythm abnormality.
So that any possibility for cardioembolic stroke.
Okay, that's okay. Irregularity is very important. Second thing.
For pulse,
you have to quickly tell all these things. These are our basics. Because we are not examining patients in detail most of the time. We'll be depending on the CT, MRI. But if you work in an area where it is not available, these things may have a good value. So one is irregularity, that is you rightly told. Second thing is?
Pulse rate, if it is...
whatever it is, rate or rhythm abnormalities are very important. Second thing? It is not so difficult.
BP.
Huh?
Next BP.
Pulse only I am asking. Absent pulse. Absent pulse is very important. There are patients who are having aorta arteritis, aortic aneurysms, or coarctation of aneurysm, or coarctation of aorta. So many abnormalities. Aorta arteritis is very common in female patients. Okay. So absent pulse is another important thing. Then absent pulse in any of the limbs. Okay. Then next. Bradycardia. What is the importance of bradycardia? What is the importance of bradycardia in a stroke case? It is very important. So when you are treating a patient with a stroke, if the patient is having severe bradycardia, then you have to suspect a raised ICP. Okay. Now, but what is the importance of BP? Same like that. Next is BP. What is important?
If it's hypertension with bradycardia,
Hypertension, Cushing reflex. Then
hypertensive bleed and
hypertensive bleed can occur. Then
Even in treatment also we have to know the BP. We have the targets for
okay, targets for BP is very, very important to prevent the secondary brain. Same like pulse, we told we have to check all the limbs BP in a suspected case of stroke, because sometimes same thing can happen. BP will be high on one side, low on another side, like coarctation of aorta. Okay, what will happen in coarctation of aorta?
there will be decreased flow in the lower limb.
BP?
BP will be low in the lower limb.
Low in the low. Aorta arthritis? Aorta arthritis is a problem in female patients especially. What will happen to the BP?
Arthritis also.
One side it will be high, one side it will be normal or low. Okay. Coarctation of aorta, that we told already. Aortic aneurysm.
If it is rupture, then there will be difference in the.
Okay, so there sometimes you get low BP in the lower limb. Okay, so pulse BP. Saturation is third one.
We have to maintain above 94% in
So
stroke
saturation
patients
should be maintained above
94 to prevent
94.
secondary
Okay,
drainage.
okay then. Pulse BP, temperature, third one. Fourth one is temperature. What is the importance of temperature?
We have to maintain the like hypothermia to prevent
Brain injury.
not prevent hypothermia.
Prevent hyperpyrexia is
and
very important. Increased temperature is a very dangerous thing in patients who are having stroke, myocardial infarction, seizure, all these things. So high degree temperature should be controlled. And some guidelines says you keep it a lower temperature, it may perfuse the brain well. Okay. So that is another argument. Then pulse BP, temperature. What is the next one? Sugar, blood sugar. So the basic things we do in every patient. Blood sugar, what is importance?
Have to maintain between 80 to 180.
Okay, so we have to maintain, it should not go hyperglycemia or hypoglycemia. Both are dangerous. And stroke, you can get all the types of sugar abnormalities. So these things we have to take care. Okay.
Then we, in this patient, we proceed with MRI, brain with MRI angiogram. In MRI brain, no.
Why you selected MRI angiogram? Why didn't you select CT? Why didn't you select MRI? Plain MRI? Why didn't you select plain CT, contrast CT? Why MRI angiogram?
In CT, we have to, most specifically, we can see bleed.
So CT is mainly done when there is a bleed. Okay. So you are suspecting a bleed, CT will be a good investigation. MRI,
we can see both, more
we can see
infarct.
basically infarct and sometimes bleed also can. Then MRI with contrast.
MRI, we can
MRI
see the
with contrast or so CT with contrast. What are you looking for? Can you pick up stroke in that? Mass, meningitis, all these things. Contrast will be better. But here you are going for a
MR brain with MRI.
MRI. Where you look for MR venogram?
If it is venous.
So a patient coming, like especially postpartum patient or young patient, female patient coming with the possibility of CVT, like you told, you have to go for venogram. Okay.
In this patient, there is left IC 80% occlusion, and in angiogram, it's in left. DCA study was done that shows left IC short segment near total occlusion.
Okay.
So that in this patient,
so where was the weakness this patient had?
Right lower limb weakness.
Right lower limb weakness. There is a lesion near carotid artery.
IC, internal carotid artery, and they done angioplasty stenting and admit the patient, done angioplasty stenting and discharge with the antiplatelets.
So a patient coming to your care, under your care, angiogram is one option here. Angiogram, angioplasty is one option. But suppose you are not able to do all these things, what else you can do?
We can look for ABCD2 score can be done. If it is more than 4, we can start on dual platelets. If it is less than 4, we can start on we can start on aspirin and also clopidogrel or ticagrelor. We can start on
dose of aspirin.
Aspirin we can start with between 160 to 325 mg. Clopidogrel 300 mg.
Okay.
And 300 to 600 mg. Anticoagulant 180 mg.
Okay. With dual platelets. Next is.
If it is less than 4, we'll start on single platelet. If it is more than 4, double platelet.
Okay. Along with that, what else you start? Statin. So statins are very important. Okay,
Lifestyle modifications and
so suppose sugars are cholesterol is normal. Will you start statin?
yes.
What is the role of statin there?
Prophylactic.
Not prophylactic. What is the role of plaque stabilizer? That is the answer for that. So there is a plaque formed in the artery that has to be stabilized. For that, statin is the drug of choice. So cholesterol is very high. There also statins are the drug of choice. How much statin you give? What is the statin you are giving? Atorvastatin.
Start dose is 80
milligrams. If it is rosuvastatin, what is the dose? Rosuvastatin half the dose, 40 milligram. And if you start atorvastatin 80 milligram, you may be continuing 40 milligram daily. And rosuvastatin 40 milligram and 20 milligram will be continuing. What is the common side effect of statin? Common side effect. Myopathy. Myopathy is the common side effect of statin, especially atorvastatin, and liver injury also can occur in some patients. So in a patient who is on atorvastatin, after 1 or 2 weeks, you can check the CK. But rosuvastatin, that elevation of CK is not that much high like atorvastatin, but still it can have, patient can have. If triglycerides are very high, what else you add? What is the second drug to be added to statin? In high cholesterol level. All these things we will face in some patients. Ezetimibe is a preventive drug that prevents the absorption of the cholesterol from the intestine. What is the other drug? Fibrates. Fenofibrate, like that. Okay. So you can add fenofibrate to existing regime, that is statin. The triglyceride levels are very high. Okay.
So, coming to the discussion of transient ischemic attack, it's a transient episode of neurological dysfunction by focal brain or spinal cord or retinal ischemia without acute infarction. We also check for stroke mimics in case of TIA, like seizures, post-ictal paralysis, thought paralysis, and syncope, and complicated migraine, and brain neoplasm or abscess.
What is complicated migraine?
Complicated migraine presents with stroke-like features.
Okay.
Neurological abnormalities. Epidural, subdural hematoma or subarachnoid hemorrhage, and also hypoglycemia, metabolic abnormalities, hyponatremia, hypertension, encephalopathy, and hyperosmotic coma or Wernicke's encephalopathy.
What is Wernicke's encephalopathy?
It is present as a triad in case of alcoholics like ataxia, ophthalmoplegia, and confusion.
Alcoholics or something else? B1 deficient. Alcohol. It is not only seen in alcoholics. Where else you can see it? Where else? Which other case you can see it? Common case.
Recurrent vomiting, starvation.
Where? Pregnancy. Hyperemesis gravida. Okay. That there also you can get same like features. What is confabulation?
Cooking up stories.
Filling up the gaps. That is a classical finding seen in thiamine deficiency. For such of psychosis, Wernicke's encephalopathy.
And in case of TIA, there is typical and atypical features. Typical features is like unilateral symmetrical weakness of face or unilateral weakness of upper limb or lower limb.
This patient had only lower limb weakness. No? Why it was like that? Paraplegia? No.
No,
single leg.
Okay. Hemisensory loss or aphasia. Typical features like blurring of vision, dysarthria, isolated ataxia, isolated dyspnea, vertigo, and isolated slurred speech. And in pre-hospital setup, we can do FAST score. FAST score is facial drooping, arm weakness, and speech disturbance from the time of onset. And in case of, and also we can do ABCD2 scoring, that is age is more than 60 years, that will give 1 score. BP, if systolic is more than 40, diastolic is more than 90, will give 1 score. And clinical features, if it is unilateral weakness, 2 scores, and if it is speech disturbance without weakness, we'll give 1 score. And duration of symptoms, if it is less than 10 minutes, if it is 0, 10 to 60 minutes 1, more than 60 minutes 2.
What is the score here?
Here it is 4.
4.
And presence of 2 or more TIA events at 7 days, we will do. And diffusion weighted MRA shows changes. We start on antiplatelets. If it is less than score 4, aspirin dose 160 to 325, clopidogrel 300 to 600, ticagrelor 180 mg, and we'll continue with aspirin 75, clopidogrel 75, and ticagrelor 90 mg BD, and also with statins. And the risk factors is age is more than 65 years, and recurrent TIA in 1 month, and stenosis is if it is more than 50%, if it is, and the ABCDT score is more than 4, diabetes, hypertension, and the duration of the TIA is more than or equal to 10 minutes. And and according to the protocol, if there is a TIA symptom, the first assessment should be within 10 minutes. And we have to report the stock medicine within 15 minutes, and imaging should be within 25 minutes, and interpretation within 45 minutes. And if it is stock, we have to do the TPA within 1 hour and admission within 3 hours.
What is golden hour concept? Extended golden hour, golden hour.
1 within 1. 4.5 for thrombolysis. We have to advise the patient for lifestyle modification, stop smoking, alcohol, and control diabetes, hypertension, and dyslipidemia.
How do you control diabetes in this patient? This patient is diabetic, no?
Diabetic, already on metformin and glimepiride.
What is the HbA1c in this patient?
HbA1c is 7.
7. What is the ideal way of controlling diabetes in this type of patients? Is it a target organ damage? Yes or no? So it's a target organ damage. Once the patient has developed target organ damage, tablets OHS will help to control the sugar, but OHS will never control the vascular complication of diabetes. That we should remember. So it is better to put the patient on insulin always when the patient has already developed myocardial infarction, stroke, renal damage, whatever it is. So it is better to switch to insulin. Okay, so this patient is an ideal candidate for early initiation of insulin. Okay, but if you continue on OHS, sugars will definitely get controlled with your tablet, but the complications due to diabetes will progress. Okay. Anything else?
Similarly, like the past series score, we have the race score now. Race score contains facial palsy, motor weakness, lower limb weakness, aphasia or agnosia, and if the score is more than 4, 81% sensitive for developing the large vessel occlusion. So we use the race score nowadays, and the golden hour is 4.5 hours, but according to the wake up trial, we will do the MRI stroke protocol. If there is a diffusion mismatch is there, we can again go for thrombolysis. Extended.
Anything else you want to add? Okay. Thank you.